Thank you, Gretchen, and welcome everyone. I'm Jewel Mullen, Associate Dean for Health Equity at the University of Texas at Austin, Dell Medical School, and I'll be moderating this session. In this panel, we'll discuss approaches and strategies for engaging with communities before an infodemic and during a public health emergency when the information ecosystem is more volatile. We will also discuss building trust within communities. In the previous panel, one of the comments that was made was that we need to fill the gap between what we know and what we can do. And I suggest that this interesting panel that we're about to hear from represents exemplars of the people and the work that's done to actually show what to do and how to do it. I'm going to invite each speaker to share their remarks. Each one has about 5 minutes to speak, and then we'll have a question and answer period. I'm going to introduce the speakers by name, and if you'd like more information about them, please note that there's a link to their bios that's been posted on the event webpage. If you have a question to ask the panel, please put in the Q&A window beneath the video player. So we are going to hear from Teresa Wagner from the University of North Texas Health Sciences Center in Fort Worth, Susan Kansagra from the North Carolina Department of Health and Human Services, Claudia Regalado-Cattouse from the Chicago Cook Workforce Partnership, and Monica Schoch-Spana from the Johns Hopkins Bloomberg School of Public Health. Teresa, we'll start with you.
Thank you. And good morning or afternoon, wherever you're at. I'm happy to be here today. My comments are going to center around, as mentioned, understanding and supporting the public in infodemic preparedness and response. And we've spent a lot of time building capacity in Texas since the pandemic. And really in 2019, I actually wrote a blog entitled Pandemic versus Infodemic, which is causing more harm. This was written in response to the vast amount of complicated and often incorrect health information around the public health crisis that arrived relentlessly through email, social media, and many of these things have been mentioned today. And I'm glad that I get to comment. Traditional media, personal messages, colleagues, friends, relatives, healthcare providers, government press conferences, and organizations trying to contextualize advice in a relevant way. People were literally bombarded with information using words such as underlying conditions and abstract statements like flatten the curve and trajectory models. And in an article at the time discussing this global epidemic of hard to understand information spreading rapidly through social media platforms and other outlets, Zarauskas proposed this lack of health literate information had devastating consequences to public health, well-being, and economies across the world. And I actually specialize in health literacy, and that's really what drove my passion towards building the infrastructure. And I asked myself, how do we engage communities and build trust and resilience against misinformation and disinformation to prepare for the next public health infodemic? Even at that point in the pandemic, I was advocating for community health workers as the conduit of health literate information in often hard to reach communities. And we saw that play out through the next 2 years. In the face of a public health crisis, health literacy becomes a global resource and community asset. Health literacy has been shown to have a direct link to poor health outcomes, especially disproportionately in minorities across the country. And it is estimated that approximately 9 out of 10 U.S. adults have limited health literacy, with rates higher among the elderly, minorities, poor persons, and those with less than a high school education. However, enhancing health literacy in populations and systems is critical not only in socially disadvantaged groups, but across all demographics. And at that time, White House Coronavirus Response Coordinator, Dr. Deborah Birx, said we really need to make sure that every household is aware of what it's going to take to protect the individuals in that household. So how do we do that? Well, of course, community health workers, and I know this has been talked about already, but really, and especially in the state of Texas, we have a lot of gaps in public health service, and we have a lot of gaps in healthcare, and we have a lot of rural communities that have no resources whatsoever. So we accepted that challenge and set out to build capacity in our communities, not only by leveraging foundational relationships that we'd already established as a part of our everyday work, but also operationalizing them, forming community-based participatory research panels of key leaders and gatekeepers to inform our work. This helped shape our messaging, but how to deliver the message. I've always considered community health workers to be the conduit to health literacy. And at the same time, they are trusted members who serve the communities and their communities and can easily deliver understandable information. CHWs help people abate adverse outcomes by assisting them in navigating dynamic systems issues caused by the complexity of technical health information and exceedingly complicated healthcare systems. So for the past 2 years, we've made that commitment, I heard someone say, about recruiting and certifying CHWs in under-resourced and rural communities using grant funding to offer classes for free. We've empowered almost 200 communities in Texas to navigate misinformation and disinformation by placing CHWs by word of mouth recruiting, lay individuals, or working through libraries, healthcare systems, federally qualified healthcare systems, academia, and a variety of community-based organizations. Building CHW workforce capacity and upskilling to address complex topics such as geriatrics and maternal mortality in both urban and rural areas that often have very limited or no access to healthcare supports these communities through access, understanding, and usability of health information or health literacy. Improving health literacy provides resilience in weathering, recovering, and abating preventable harm caused by misinformation and disinformation during public health emergencies, while flattening the curve of complex information to keep people safe, healthy, and well. So we prepared our communities not only for their day-to-day, but also for future crises. Thank you.
Thank you. Susan.
Hey, thank you. And thanks so much for having me on. Really appreciate the chance to engage in this dialogue and such an important topic, infodemic, talk about words that we thought we would never have to use, and new terms that we're learning every day. So here's another one that we hear all the time, infodemic. So I will focus, I know you've heard a lot about this in the last day and a half already. I will just focus on 3 things that I think we in North Carolina learned as we went through not only the COVID-19 pandemic, but certainly with the Mpox outbreak as well. And as we look to the future, how we're thinking about how we work to build trust and engage in community partnerships. So first and foremost, I'll tell you one of the things that we did early on in the pandemic is work with and fund an umbrella community-based organization called Healthier Together that then worked with other community partners in the ground to be our public health ambassadors. And, if everyone remembers, particularly when vaccines first came out, we initially had, lots of people coming out to get vaccine, but then it was come late summer where you hit a lull, right? And then every person that got vaccinated after that point was somebody that was hard earned through a lot of proactive communication outreach. And that really was thanks to our community partners on the ground. While we were out there every day trying to share the information, having our community partners as our public health ambassadors really taking that information, making it their own for their communities that they served was really important. And so that umbrella infrastructure that we stood up, we didn't have before. That got stood up during the COVID-19 pandemic, and something that has also evolved over time. We've seen that infrastructure, again, be very important as we think about other things, whether that's MPOX or as we talk about diabetes as well, being able to provide that information to our community partners in this way. And, oftentimes we do a lot around sharing information with partners, but this was really different in the sense that we were actually also resourcing those partners for them to have the infrastructure they needed to do communication. Because so often, community organizations, particularly that are on the ground doing the boots on the ground work, sometimes they don't have the infrastructure. And for us to be able to help provide some of the funding for them to create the infrastructure they needed to further then work with their constituents was really important, not just expecting people to do it, as part of the third hat that they were wearing that day. So that was really important and something we created and learned. And I will say, with our data over time, we saw this gap early on, and I use vaccines as an example, though you could look at many different health issues, but I use COVID-19 vaccines as our example of where, we saw huge gaps initially in who was getting that. But over time, we were able to close, particularly for our older adults, 65 and over, we closed the disparity gap between our Hispanic populations and our white populations and narrowed them significantly between our African American and white populations. And so that, happened over time. And I think thanks to a lot of the boots on the ground work with this group. Second thing I'll mention is, our communications team at the department worked really hard to understand what they were hearing and seeing on the ground and what the misinformation was that was circulating in our communities, what we were seeing as replies, to our social media, and then worked really hard to think about what were ways that we could share the right information. And it's always tricky, right? Because you don't know whether sometimes you don't want to repeat misinformation, put that out there, but you do want to make sure people get what they need, and how we can make sure the right science, right evidence is getting out. And our comms team worked really hard to understand the landscape, to focus group a lot of our messages, to be able to better refine and tweak. We had a slide deck called COVID 101. That was our deck that we used with lots of different partners, and that deck every day got refined based on what we heard from the partner that we presented to that day. So, if something didn't make sense, if it didn't address something that they were hearing out in the community, we got that feedback, and every day there was a team updating it and putting that new deck, back on the share drive for us all to use and build from. And so, being able to do that proactively, again, was only successful because we got additional funding to be able to do that over the last 3 years. It's very hard to be able to maintain that type of proactive surveillance that we were doing of communications, not just surveillance of data, but surveillance of what we were seeing out in social media to be able to do that. But incredibly helpful. And we also worked really hard to create like short video snippets where we would address an issue, for example, vaccine infertility was something that kept coming up. And so we were creating short informational pieces and videos and having community partners help create some of those things so we can get that information out. And then the third thing, and last that I'll mention, really important is, as we look to the future and as we think about the last 3 years, certainly we were on the reactive end of a lot of queries, but being on the proactive end of sharing what public health does every day, I find so important. And that is something people often don't realize that, if you go to a restaurant, we were there, we, are making sure your food is safe to eat. If you have a child that goes to a childcare facility, we were there also. If you're building a home, we've tested the soil to see if your septic system can be put on that soil. If your child got fluoride varnish in school, that was us, right? There's all these things that we as public health teams and partners do that people don't often realize. And now is our opportunity to also continue to be proactive in sharing what public health does every single day and how that impacts, you community member every single day, though you realize it or you might not. But being able to share those proactive messages, I think, is really important now as we go into the future, especially because there is so much coming at people, and being able to cut through the clutter and explain how we benefit you on a daily basis is really important for people to understand as we look to the future and as we think about other ways that public health may have to, rise to the next challenge. But building on that base and providing that foundation is really important. So I will pause there and I'll turn it back over to you, Jewel, to take us the rest of the way. But thank you for, again, allowing me to share a few comments and experiences from North Carolina.
Thank you. We're building on great comments on top of more. And now it's your turn, Claudia.
Thank you, Jewel. And hello, everybody. Good afternoon or good morning. So my name is Claudia Regalado. I am from the Chicago Cook Workforce Partnership. I think I come with a different twist here. The organization that I work for is the public workforce system for the city of Chicago and the county, Cook County. And how we came into the picture for public health was through a grant back in 2020 through the contact tracing. The city of Chicago contacted our agency and did a procurement. I think that with Dr. Allison Arwetty's, expertise and the way that she wanted to manage the pandemic made sense to us in regards to how do we reinvest, knowing that a lot of people were losing their jobs, but also dealing with the COVID-19 crisis. So through this grant that we were able to procure and win, we actually started with the contact tracing call center. So we ended up procuring ourselves 31 agencies in the city of Chicago to hire people from the community to serve their community members through this contact tracing call center. Of course, I don't think that we've really ever been here with this type of situation where we didn't know what to expect from the contact tracing. So one of the things that we actually identified is that there was some type of mistrust from community receiving these calls from a government agency and releasing information about their health. So the calls were not coming or trickling in as we expected. So the data was not, we hired 600 people to answer these calls on a daily basis. And a person was probably getting 1 to 3 calls, most 5 calls a day. But again, we started identifying and we switched the conversation of why were people so hesitant to release information so we could be providing them with the resources that they needed. Because of that, this happened around November 2020. We needed to re-strategize, and I think I heard Phil on the other panel. What I say today might not be the same thing I say next week. Well, for us, we found out is what I say today is not the same thing I'm going to say tomorrow. We had to really pivot almost each day based on whatever the situation was and the information that we were gathering from community residents. Luckily, what happened is that in December, the vaccination was released and we were able to now pivot in using the vaccination as a key way of now connecting with community members in another way to get them vaccinated. So surveys started trickling down. We would, like Teresa said, we were on the ground, boots on the ground. But these were people that were your neighbors knocking on the doors or calling their community members and asking them and trying to get information in regards to why they were hesitant to get their vaccination. And the same model, these individuals that were hired were very entry-level individuals with probably little to none knowledge of public health. And we understand that when you're from the community, the only time that you would really hear the word public health is you walking into a public health department and asking for insurance. That is as much as many of these community members know what public health means. So here now we are having these individuals from the community being the middle person for CDPH, which is the Chicago Department of Public Health, and the community, and being the translator for both on how we could connect and get the data from the community members to CDPH and for CDPH to actually translate all that information so community members could actually understand all the benefits that they would get from public health, especially around the vaccine. Because of the vaccine, we had one of the biggest call centers created for the United Center. We used 300 of those contact tracers who became now the COVID-19 Customer Service Center. And these individuals now started getting data, doing case management, not case management, but more of informational management, of asking the questions that we needed in order to understand how to mobilize individuals on the ground to get them into, not convince them to get the vaccine, but educate them on the vaccine, that they would be able to make that decision and know that the government was not there to go get them, right? And I think that that is one of the biggest components, and one of the biggest lessons that we learned is, how do we collaborate together so there could be that trust built between government agencies and the community members to be able to work together for, to accomplish what it is that we needed to do. And this was get people vaccinated. From there, projects started trickling, and now we became more of a community health response corps, that we were not just targeting COVID-19, but, Mpox, came out, and we used the same model to be able to get people informed, educated, and vaccinated if needed. Then we had door-to-door knocking. We had our core members really knocking on the door, with a survey that was created by the University of Illinois Chicago School of Public Health on vaccine hesitancy, gathering that data to understand why people were still not vaccinated, having virtual hall meetings, building relationship with CPS, which is the Chicago Public School System, and reaching to parents in that area. So there were many ways that these community members not only were hired, right? 70% of the grant that was provided through the city was spent on wages to support the core. So not only were we tackling the pandemic of COVID-19 crisis, but we were also building an economic development and bringing the money to the communities that need it, because these individuals actually, needed this income for their, because they lost jobs, right? So there was a lot of twist into how we managed this, but luckily we're still here, and yeah.
Thank you so much. Let's hear from Monica, and then I look forward to getting all of you in conversation.
Thanks, Jewel. Greetings, everyone, and my gratitude to the organizers for this opportunity to share my thoughts. In the interest of 5 minutes, I'm going to front load my 3 takeaways. The first is that a key strategy for dealing with infodemics involves actually turning that concept on its head, which I'll explain. Secondly, that community engagement is a strategy that can help fill that information void at the top with vital intelligence from below or at the front lines. And then lastly, the circulation and integration of community-held knowledge hinge on intent and infrastructure. So my first point, much in the same way that the World Health Organization Constitution defines health as not merely the absence of disease or infirmity, but a state of complete physical, mental, and social well-being, we really need to rethink the infodemic concept. More specifically, I'd argue that we need to shift away from the idea of the population or communities getting the facts wrong to the public health authorities getting the right facts with which to design and deliver services that communities deem trustworthy, beneficent, and useful. So that's my first point. The second point is about the power of community engagement to support successful public health interventions. The working group on community engagement in public health emergency planning, which I co-chaired in 2006 and 2007, defined community engagement as structured dialogue, joint problem solving, and collaborative action among authorities, citizens at large, and local opinion leaders around a pressing public matter. And we contended at that time that when the community is involved in preparedness and response systems, they can offer ideas, insights, and practical support that enable public health interventions and clinical care to be more culturally competent, attuned to local conditions, and socially acceptable. So that's a theory. What does it look like in practice? Communivacs, which I co-led in 2020 to 2022 with Emily Brunson, was a national rapid research to action coalition. It involved social scientists, community advocates, healthcare providers, and public health experts. And we applied community-based participatory research techniques and undertook community engagement activities to advance COVID-19 vaccine equity and also to strengthen local community health systems. So just, to distill this, our 6 local teams listened as members of local Black and Brown communities explained in their own words, rather than those of pollsters, their experience with the pandemic and what was affecting their willingness and ability to be vaccinated. So rather than an education campaign to correct misperceptions or unsafe behavior, the exchanges were conversational and non-judgmental. The local Idaho team, for instance, incorporated about 20 student researchers, most who had ties to the Hispanic communities living in the rural and frontier southeastern portions of the state. And that local team met weekly and biweekly with Southeastern Idaho Public Health. And a critical learning early on was that the community's emphasis on work, being healthy enough to work, working to put food on the table, was a key motivation for getting tested and vaccinated. So with that input, the public health district decided to conduct on-site vaccine clinics at the local farms and the food processing facilities that predominantly hired Hispanic workers, thus aligning the intervention with a meaningful community value and also providing easy access to the vaccine. So my last point is that intent and infrastructure are necessary for genuine and sustained community engagement. The research here, in 2012, colleagues and I undertook the first national survey of local health departments to baseline their community engagement practice and identify the traits of high-performing local health departments in relation to participatory emergency preparedness. And then we refielded that survey in 2015. And together, our multivariate analyses firmly underscored that allocating funding, assigning experienced staff, and holding a formal community engagement policy enable more intense participatory approaches to public health emergency preparedness. Having strong community partnerships was also an important influence. So to close, I would just say that apart from laboratories, epidemiologists, and informatics, efforts to modernize the U.S. public health infrastructure must include greater capacity for genuine and sustained community engagement. So thank you for your time, and I look forward to the larger conversation.
Thank you to Monica and all of the panelists. I hope everyone understands why I described you all as bringing the how-to, because you have. And because of that, there are a few questions I could ask that I'm not going to start with. Instead, I prefer to direct a question that's come in from the audience for Teresa, but then invite anyone else to also respond. And the question is, Teresa, whether or not you can provide published data that shows some changes in habits from your information delivery using community health workers. Was there any measurable effect directly related to your team activity?
I think there's a lot of foundational research. We didn't do any, for one, it's been too short of a period of time, but also we didn't do any particular outcomes research here. We are about to embark on that. But there is foundational research available through NASHWA, the National Association for Community Health Workers, that indicates that they are beneficial in a variety of ways in terms of health outcomes.
Thanks. And before I go to my follow-up, does anybody want to add anything to that?
I'll go ahead and add. Here in Chicago, what we did do, we did research, or we did pre and post survey of our core that, again, had no knowledge of public health to where they're at now. I believe in the last 2 years, 2.5 years, we've had over 800 people come through the core. And we've had data collected from the time that they started to where they're at now. Some people are actually now working for CDPH. Some are actually getting their degree in public health. Some have turned into CHW. So we here did collect the data to see the track of an individual coming from the core to where they're at now.
And actually, I wanted to add, I do have a couple of encounters, I guess you would say. One is that we worked with a community health worker in a rural community that had the highest rate of COVID-19 to find out why the information was not reaching the Hispanic population, who actually worked in agricultural and other industries that were frontline industries. And so what we found through focus groups that the community health worker held was that the information was being put in on the website for the healthcare system in English only. And many of the 60% of that community had no access to the internet and did not speak English. So as we moved through that particular circumstance, what we found was that, and it is interesting to me, that using things like flyers, churches, direct mail was, of course, in Spanish, was the better way to communicate with that particular population. And then just as far as the day-to-day, we have done a study where we taught community health workers, I talked about the upskilling, about diabetes management. And we had good outcomes from that particular study where the A1Cs of their community came down to within sevens. So some good outcomes from that particular study as well.
Thanks. We have another question from the audience, so I'm going to ask my follow-up and then get to our next audience question. And informing this in part by 5 words I wrote down from Monica's presentation, some of which have been floating through my head this morning. Talking about information that's trustworthy, beneficent, useful, and then the importance of intent and infrastructure for public health. And so, we get asked the question about the evidence. So let me get your panelists' opinion on what potential indicators might be or proxies for them for measuring trust, resilience, behavior change, social cohesion, or depth of community engagement.
Anyone? I'll take a stab at what you're asking. I actually probably will answer it maybe a slightly different way, but Monica, I really appreciated your thoughts and comments. And, I will say the other piece around thinking about trust and how we measure that is really making sure we are intentional in measuring our actions and how we are reaching communities. And again, I just go back to the vaccine example. You know, I'm not going to talk about a measurement around what you named, Jewel, but we did measure, you know, for every provider that got vaccine, who they were vaccinating and were they members of historically marginalized populations. And then we use that data to make decisions on who got more vaccine. And so, you know, we were not only talking about it, but we were really intentionalizing operational infrastructure that then valued those things that we were saying we were going to show in our data and be transparent about. And I think a lot of that trust, right, is built in the intentionality of those operations and how you're making those operations very visible and doing what you say you want to do. So, you know, I'll just add that lens. And I think that was really important. And we learned that not just through COVID, but again, you know, as we thought about Mpox and that outbreak and how we got vaccines and how we were really transparent with our data to show, you know, North Carolina, and then, you know, you can see this nationwide, that the people that were most at risk of, you know, having Mpox were not the ones that were getting vaccine, and being transparent and accountable collectively for that data, and then using that to be intentional in your outreach and outcomes.
If I could follow up, Susan, thanks for the question, Jewel. I'm biased here. I'm a cultural anthropologist, so I'm going to make a pitch for mixed methods for whatever way we're measuring these concepts, firstly. So the second point I would offer is perhaps a first step for a local health department is to actually query members of the community or their representatives. What do you think is important for us to monitor, to know that you see us and feel us as a trustworthy agency? So again, we need to turn some of this, turn our approaches on their heads. And so that includes, you know, deciding what we're going to monitor. I coming from the community resilience field as well, that assessment or that self-assessment should involve, you know, a collaborative discussion about what priority indicators there should be. So anyway, but I look forward to what Teresa and Claudia also have to say.
Monica, I was just smiling at everything that you were saying, because I truly believe, and from the experience that we received and went through, is having the community members at the table. It's, you know, one of the things that I say is, you can't come into my community and tell me what's best for me if you don't live in it. So hearing them out and asking them the real questions, right? Why are you having this mistrust? You know, not from a government, highly educated individual, you know, but from a person to person conversation, you know, human to human, you know, why and how and what do you need from us, you know, hearing people out. And I think that that's what one of the things that was really nice about the core is that they were community members speaking to other community members and gathering that data for us. And then having CDPH at the table to listen, right, whether they liked it or not, you know, this is the reality and this is how we have to move in order for us to move forward and make traction of where we want to go. We have to listen to community members and what they have to say.
Yeah, and I have to just say, you know, verify that, because as I mentioned, we used a community-based participatory research group that we had built relationships with over time. So these people are our colleagues all the time, not just when the pandemic hit. And we would meet weekly during the pandemic and really listen to, as you've all mentioned, what they had to say and what was it that they were dealing with at that point in time. And it might not be our agenda, you know, it might be, we had, if you all are familiar with the famous ice storm we had in Texas during the middle of the pandemic, there was one week when we all met and they were like, we don't need your help with COVID-19 right now. We need clean water. We need, you know, blankets, whatever the case may be. And so we redirected for that 2-week period of time while everyone was in recovery from the ice storm. So Yeah, definitely need to listen to the community and find out what their priorities are.
I remember the ice storm. So as promised, the next audience question, which the person who asked it calls it personal, but I think it's another question on behalf of the communities that we're talking about. I'm disabled and work at a center for independent living in a community of people with disabilities, many of whom distrust doctors for good reason. How can I best help combat misinformation in my work?
Yeah, again, I would say, many of the things that we've already talked about today would be how you would want to do that is, maybe listening to your constituents and finding out what the mistrust and misinformation is that they're struggling with. And then, figure out how to make resonating messages and then test the messages with that group so that what you're saying or doing moving forward is relevant. One of the projects that I'm working on right now is actually heat mapping vulnerable older adults and people living with disabilities in the Tarrant County area, and then overlaying community health workers and heat mapping that together so that we can make sure that there are community health workers in all of those areas to help bridge that information gap during the next public health emergency and or just on a day-to-day basis. So they can go ahead and be building relationships now.
Yeah, and I think that's great ideas, Teresa. And alongside that, I would add that that individual can actually be an educator of practitioners of all kinds about ableism in our approaches to preparedness and response. And I bring this up from from a personal perspective in that I was invited to give a keynote at the American Association for Cerebral Palsy and Developmental Medicine about resilience in the COVID-19. And I thought, what do I have to share with this audience about resilience? The parents and providers and individuals themselves with CP and other developmental issues demonstrate. So the point here is there is much to be learned, I think, by those of us who work in public health emergency management about the way that ableism actually structures our approaches. We at the Hopkins group did a deliberative democracy approach to, and this is pre-COVID-19, the allocation of scarce medical resources in disasters. And while we were very, very careful to include within our demographics people across different economic tiers and also racial and ethnic categories, we were completely blind, I have to sadly say, about the issue of people with different abilities from a mobility and other aspects. So ableism is a problem, I would argue, and that individuals should be encouraged to educate their local agencies about the needs of this particular community.
I would like to add that we are in a time where it's multi-generational, multicultural, multi-everything. And sometimes we need to understand every different bucket. For the pandemic, I could not speak to a senior the same way I would speak to an 18-year-old, right? It's different messaging that we would have to focus on to get our point across so they could understand the knowledge and the message that we were giving. Because of that, we in Chicago, in the Cook County, we have created now a program. It's funny that that question came up right now because we just launched it about 2 weeks ago, and they are called the Career Pathway Service Navigators, and they're specifically serving people with disability. So this navigator will actually, support that person, not only with workforce development, but understanding what they need due to COVID, pre-COVID, resources that they need. So this individual is hired specifically to serve the community and build relationships with employers, public health, every entity or CB or other community-based organizations to formalize a one-stop center, basically, for just specifically for this community.
The only other thing I'll add to that, question that was raised is, I feel like it's really important also for, those conversations for us to humanize each other. And when I say each other, doesn't matter who's on the other end, whether that's a, community partner talking to another community partner, patient talking to doctor, government official talking to somebody. We oftentimes, and I feel like especially these days when a lot of conversations happen in formats like this, it's easy to dehumanize each other and not realize that person is also your neighbor or your friend or your friend's friend or whatever that is. And I think those are the conversations and connections that enable then for real dialogue. And I think, for this person is asking what I can do. Well, what an amazing opportunity, especially if you're on the ground, able to talk to, others in your community, be able to bring that one-on-one connection and humanize some of the things that we oftentimes take for granted. And to me, that feels like the, one of the broader things that we are seeing in this infodemic is that, people are being dehumanized when they're delivering messages and being kind of painted all with one brushstroke. And I think bringing that opportunity back through some of, this opportunity to have one-on-one conversations and, that we need more people on the ground being able to do that.
I think that's a perfect place for us to conclude with the reminder and thanks to that last questioner, that their trustworthiness, beneficence, and usefulness, there's no one size fits all to that either. But I think our panelists all just reflected that. So thanks again to all of our fantastic panelists. Thank you to the public for your questions. Now we're going to take a short break for 30 minutes. And when we return at 12:45 Eastern Time, we will have a conversation about preparing for and responding to infodemics in diverse communities, moderated by Vishwanath. Thank you. We look forward to seeing you in 30 minutes.